Hi, this is Kendrick Johnson with themedschool.com. Today we're going to do a quick review of headaches, and we'll start with epidemiology, just a short note on the epidemiology, go through a differential and discuss some of the most important types, and then we'll talk about how you work these up and how you treat them. So headaches is a problem that causes over 150 million lost work days per year. This is specifically migraines that cause this, and other headaches can play into, but of course migraines is going to be one of the biggest reasons for lost work days. So there's lots of different types of headaches. This list is not even close to covering even a third or a fourth of the types of headaches that you might see, but it will cover the most important ones, and these are the ones that are covered in the two review books that I'm using. So they're in theory they're going to cover most of the ones that are going to be on the boards. And the top two, the tension and the migraine headaches, make up around 90% of all headaches presenting to a primary care setting. So if we know those pretty well, then we'll have a handle on a lot of them. And then the others, there are some others that I included here just because I thought they were important to mention. So let's start out with the tension headache. This is the most common type of headache. It's going to present bilaterally in most cases, whereas the other common types of headaches like migraines are usually going to be unilateral, so just on one side of the head. People describe it as being a band-like sensation, like something's around your head constricting it, usually a dull type of pain. These will get worse with stress, but they're not going to usually get worse with like light or activity or loud noises. So they are, in most cases, going to be fairly constant, but they will wax and wane. That sounds like it's backwards. So they do wax and wane, but they're not going to be affected by activity. So in depression, this is usually the chronic headache that is associated with depression. And a lot of times you'll see a pattern where it's kind of affecting the forehead and the back of the head as well as the neck. A lot of these are going to be associated with neck pain. And some can be triggered by neck pain, neck stiffness, and that type of thing. So that's going to be a common theme that you'll see. And a lot of these will improve with massage to the neck and things like that. We'll talk about that in treatment, but there's been a lot of ties to musculoskeletal neck problems and tension headaches. So the way to diagnose this is just to make sure it's not anything else, especially temporal arteritis, which has somewhat of a similar presentation. It's just the major one that we need to rule out if this is on the differential. So to treat it, we need to reduce stress, whether that be by massage or by meditation type techniques, or any stress management like biofeedback can have a big effect on tension headaches. NSAIDs and acetaminophen are going to be your first line medical treatment, and you can use triptans in these, but triptans are usually associated with migraine and some of the others that we'll talk about. So I'm throwing temporal arteritis in here, not because it's real common, but because I just mentioned it, and so I just want to clear it up if anybody's wondering what it is. So this is going to usually present unilaterally. So they'll feel it on one side of the head, and a lot of times it's going to be kind of a temporal pain. You know, they feel it in their temples, and they'll also have some jaw claudication, you know, where they're chewing and their jaw hurts or gets real tired. And that temporal artery is often visible and tender. And around 50% of these people also have polymyalgia rheumatica. So you may have some muscle pains associated with this, and you want to start thinking about temporal arteritis. If you find temporal arteritis, then work them up for polymyalgia rheumatica. If they already have polymyalgia rheumatica, then make sure you're keeping an eye out for temporal arteritis. It's extremely rare under the age of 50. There are cases, but you want to make sure that this is on your diagnosis for anybody over the age of 50. I didn't mention here sight vision loss under the presentation, and I should have, because sometimes that's going to be your presenting feature. Hopefully not, because a lot of times this is permanent blindness we're talking about. If you have a new onset of vision loss in somebody over the age of 50, and they're having a headache like this, then you're definitely going to go straight to temporal arteritis on your differential. And the diagnosis is you want to use an ESR to rule it out. So ESR is pretty sensitive. It is not specific, obviously, since it can mean just about anything. But if they don't have an elevated ESR, then you usually can rule it out. But you need to do a temporal artery biopsy to know for sure. Before you even get to either of those tests, if this is high on your differential, you give them a high dose of prednisone. So you don't wait for the biopsy to come back to make sure, because if they've already lost vision in one eye, you want to save the other eye. And if they haven't lost vision yet, then you want to make sure that they don't. So go ahead and give the high-dose prednisone if this is on your diagnosis or your differential diagnosis. And it's going to help. High-dose prednisone can help treat some of your other headaches as well. So it's not a bad thing to give, especially in some of the more serious headaches. And the major complication is blindness, and it generally is permanent. So it's an important thing to have high on your differential and get it ruled out quickly. So back to the common ones, migraine is an extremely common problem. I mentioned 150 million work days lost in a year, mainly due to migraine, and it's very much associated with a family history, and 80% have a family history of it. This is usually on one side of the head, and we usually associate it with an aura, like scotomas or tachopsia and photopsias, rhodopsins. But that's only going to be in 15% of your migraines. Now, I didn't know what any of those things I just mentioned meant, so I'm going to just tell them to you. Scotomas are like blind spots. Tachopsias are jagged zigzag lines, and those are pretty much pathognomonic for a migraine. Sometimes people will have these. In fact, I saw a patient yesterday who had these jagged lines but never had a headache. So the diagnosis was migraine without headache, and he would get these and really no other symptoms. So that's the tachopsias. The photopsias are like shimmering lights, and the rhodopsins are just changing colors that you see. Many of these are associated with nausea, and many are associated with photophobia. So those are some things that can help give you the diagnosis of migraine. They will be triggered by food and odors, fasting, stress, menses, sleep disturbance. Really, a lot of things can be a trigger for it. But basically anything that alters that affects your senses can, or hormone balances or anything like that, can be a trigger for a migraine. The diagnosis is done clinically. So if you add up these things, if they have a family history, if they have an aura, you can almost make the diagnosis just with that. But if they have the photophobias, And I didn't mention this, but it's usually a more gradual onset, and it's usually a chronic problem. So those things put together, I'm actually not aware if there is a classification system for migraine. I'm sure there is, and I should have looked for it. But look that up and see if there's a classification system to nail down this diagnosis. But you'll probably be pretty sure just by seeing these features. The treatment, you want to start by avoiding the things that you know are causing this. So you might want to have your patients to be keeping a journal of what things might be causing their migraines. A lot of people will probably know, but have them keep a journal so they know what causes their migraines. You can use NSAIDs to start with, and triptans. Metoclopramide can be used, especially when associated with nausea. And anticonvulsants and TCAs and beta blockers can all be used for prophylaxis, especially in people who have a real problem with them. Tumor wasn't included in any of the review books that I noticed for the workup of headache. And that surprised me because, that's kind of the first question that patients are wondering is this a tumor and am I going to die? And so that's why I included it here is for the patient's sake and for your sake when a patient is asking if it's a tumor. Of course, we'll be doing a video on brain tumors later, but the reason that I think that the review books don't include it is because this is only going to be less than 10% of your tumors have this as the presenting feature. So usually you're going to have a lot of other features like the seizures, nausea, vomiting, diplopia, increased intracranial pressure, visual abnormalities, neuropsychiatric symptoms, and it's more common in older adults, but it can affect children as well. And the headaches are often when people wake up. So early in the morning, they'll have these headaches, or they can, in some cases, can wake up in the middle of the night with a headache. So if you want a couple rules for when you start thinking about a tumor in a headache, because you still have this 8% that's the only thing that you're going to present with. Then, first of all, if it's 50 plus, and if their headaches come when they just wake up, those are some big cues for thinking headache. And then, of course, if they have any of these other things, recent weight loss I didn't mention, but that's one too. Any of your B symptoms. But if you have a suspicion for tumor for any reason, and if it doesn't quite fit any of the other headaches that we're talking about, then you might want to go ahead and get a contrast CT or MRI. And the treatment we'll cover in a different video. Another one that is not a big feature in review books under headache is intracranial bleeds. And that's probably because a lot of times these are going to be associated with trauma, and so you don't have it worked up in the same way. But you can have subarachnoid hemorrhages, for example, without any recent trauma, though it is most commonly associated with recent trauma. So if they say it's the worst headache of their life, if they have neck stiffness and photophobia, then definitely they're going to get a CT, a lumbar puncture if the CT is negative, and 4-vessel angiography. And the treatment is to get a neurosurgeon involved. There's also intracerebral, subdural, and epidural hemorrhages, again, usually associated with trauma. You can have aneurysms present with a slow onset headache. But again, a lot of these will be associated with other symptoms. So other neurological symptoms, that's when you send them to get further workup. if they're having any type of diplopia, galactorrhea, just anything else that would assess that would suggest a mass in the brain. Of course, you get it worked up. Trigeminal neuralgia. I actually don't remember how common this one is. I've never seen a patient with it, but it's extremely painful, and the presentation peaks at 60. It's an episodic thing, and a lot of times people will know when it's coming. They can kind of feel it. It has a type of aura that is associated with it in many cases. But it's extremely painful, and it's going to affect, in most cases, a large distribution of the trigeminal nerve. So, the trigeminal nerve is basically sensory to the face and to the cranium. So it's going to a lot of times affect the face. And the treatment is going to be carbamazepine, phenytoin, clonazepam, valproic acid. TMJ disorders are associated with chronic ear pain, headaches, jaw stiffness, and almost all of these are going to have jaw issues with it, and so it's not going to be too hard for you to see that it's associated with TMJ. And facial pain, jaw and joint noises. These shouldn't be too hard for you to recognize, but they can cause diffuse headache. NSAIDs, relaxation, stress reduction, muscle relaxants are all helpful, but a lot of these people will need a dental appliance to help them keep their jaw stabilized and in the right position. And some people they'll need a surgery. There's oral surgery as well as dental surgery that can help this. And just to end with, I wanted to make sure that some of the emergencies were covered. So if you have a headache plus one of these symptoms, then think about the emergency problems that you can have. So if you have a headache plus red eye and corneal clouding, intense eye pain, think about glaucoma and get an emergency ophthalmologic consult. Blindness, myalgia, jaw claudication we mentioned as temporal arteritis. And then any of our bleeds or tumors or any mass effect in the brain, these are often associated with nuchal rigidity, vision changes, seizures, nausea and vomiting, and neurologic deficits. You can include meningitis or encephalitis in this category too. These have these kind of symptoms. So if you're in a primary care office and they present with any of these things, you probably send them to the ER. So that picture on the front page was by Sasha Wolf from Grand Rapids, and she was nice enough to share it in Creative Commons license. If you have any comments, any ways that I can improve this video or any requests for other videos, please let me know. My email address is kendrick@themedschool.com, or you can leave a comment below the video. Thanks very much.